everyone, and welcome to this virtual event. This is Valentina from the Zermac webinar team, and I am here with my colleague Giulia, one of us for any issue. Before starting, here we are with some useful tips for you. You can use the chat to greet the speaker and the other participants, or to get in contact with one of us from the Zermac team. You can write your questions for the speaker in the dedicated question and answer box. The speaker will answer them immediately or at the end of the presentation. If you have any problems with the audio or video, you can click on F5 to reload the page. Alternatively, try to exit and then re-enter through the app while closing all other unnecessary programs. You will get a better connection if you use a network cable. Keep a glass of water beside you and a few sheets of paper to take notes. Lastly, let me introduce my colleague and moderator of this digital event, Dr. Nicholas Charles. He's a dentist and here in Zermac covers the role of professional service manager. I give the floor to him. He will introduce our speaker.
Thank you, Valentina, and welcome to everybody. First of all, I would like to welcome our top 5 countries, India, Vietnam, Egypt, United Arab Emirates, and also Serbia, for being here with us today. There are also other countries. The list I've seen, it's really important because there are over 40 different countries from where you are connecting. Thank you very much. Now, let me start introducing you the next speaker. The next speaker, I want to say that for me, he's like a mentor, because when I just started working, I did a course in his clinic, and he taught me not only of prosthodontics, and this is the best thing of Dr. Ugo Macca, because Ugo teaches a lot about the treatment plan. He's one of the rare person that really manages to make a real multidisciplinary approach in dentistry. That's why I find his words always very, very interesting. Dr. Ugo Macca has obtained a postgraduate in prosthodontics at the Boston University. Founders of the CIPRO, the Association of Prosthodontists. So I would like to welcome and to introduce you all to Dr. Ugo Macca. Ugo, you're with us?
Yes, I'm with you.
Thank you. Thank you for being here, Ugo.
Okay.
It's very nice to see you again here online, and we're looking forward for your lecture. So let's start.
Here I am. Thank you, Nikki. Who was trained in university, and Davide Mirabella, that is an orthodontist trained at University of Washington, Seattle. And together we started to work as a team in that sunny part of the world that is Sicily, specifically in Syracuse. So let's go back to that time. If I show this image, do you like it? Of course, you say no. But let's go more in deep. 30 years ago, that was the case. Complete collapse of the posterior area, the teeth that moved forward, lifting, and almost 0.5% of bone loss. Today, we know we could remove everything, make extraction, and the patient would end up with an implant-supported prosthesis. But at that time, and today as well, we love to save teeth, and using orthodontics, using periodontics, good abutment preparations, good prosthetic preparations, we had 5 solid abutments to make a ceramometric that
Recording in
change
progress.
the prosthesis need to stay for other 30 years. So this is the power of interdisciplinary treatment. So now back to the present. Today we are going to see 3 different cases. One healthy situation where the patient has an important loss of dental structure. A medium, let's say moderate situation with a problem, a disturbance in alignment and teeth distribution, and a very compromised case from a periodontal point of view. And that kind of restoration, of course, and the treatment will be different, just restorative and orthodontics, and a full case with perio, prosto, and ortho. Let's start with this manager who came to my office because of short teeth. And we know that short teeth often comes from wear and compensatory eruption with the whole periodontal apparatus that follows the teeth during its movement. So it's not a real disease, but it's an aesthetic imbalance. But let's think, what kind of wear do you know? We must distinguish between attrition and erosion. And we talk of attrition maybe mainly from a mechanical point of view, bruxism, daily or night bruxism. It's easy to recognize because we find wear facets that are smooth and with sharp edges. There is not sensitivity, usually, and the wear facets perfectly match. On the opposite, if we talk about erosion, it's a chemical problem due to different products, the most important of which are gastric juices, mainly for dietary disorders or gastric reflux. And the pathology affects the dentin. The enamel is almost entirely preserved, but we have this island of deep destruction in the dentin. So you can find fillings, root canal treatments, or any kind of restoration, and a lot of sensitivity. But going back, we have the same therapeutic protocol in these cases. Only the bite is essential for attrition, and you should remove acids if you can in the case of erosion. Going back to our case, it's for sure attrition. Patient, because I kept on showing her, let's say, beautiful smiles, but very white and big teeth. And she didn't like at all. She was afraid of this kind of image. Then I showed her a, let's say, warmer color and something generally moderate. And she loved it. So we had the road to follow, and we started the treatment. But we have other limitation. She didn't want ortho nor surgery. And how can we deal with such a deep bite without ortho surgery? The only solution is going with an increase, an opening of vertical dimension of occlusion to let the teeth move, even if we lengthen them. So we adopted the sequenced segmented technique known as three-step, proposed by Francesca Vailati and the Geneva School. So we started with two silicon impression and started with the aesthetic evaluation, going with an anterior wax up to establish the length of the front teeth. We used a traditional wax up on a stone model, but of course, nowadays you can go with a digital smile design and a printed model. But in any case, what is really important is that you make a mock-up index that is very precise, that follows perfectly the contour of the tooth on a gingival margin and the interdental areas. So you must separate very well the teeth. But when you inject this acrylic into the index, and then you put it firmly and precisely in the mouth, after removing all the excess in very accurate way, the material will cure up, and the patient must have a real idea of what the final result will be. We'd like to have the so-called wow effect. This is what I want. And in this case, she immediately showed a positive attitude to this new size and shape of the teeth. Because they are not too long, but this additive design that you can see, I guess, in the picture, move them from a retrocline position to a procline position, and enlarging the arch. So everything is proportionate, it's not too striking as she asked, and she liked it. So we can start and go to the second step, that is the real increase of vertical dimension on the posterior side. I mounted on articulator the models with Facebook bone, and we opened the pin articulator of 2.5 millimeters, as much as was needed to get the length that we proposed with a mock-up. Now we have to decide how to distribute the restorations. And if you look on the right side, we have an accentuation of the curve. On the left side, it's reverse. So we can distribute on the two lateral in a different way. Two premolars on the right and one molar on the left, in the upper, and the opposite on the lower. One molar on the right and two premolars on the left. In this way, we can flatten the occlusal plane, make it very even, and the same happens for the curve of Spe and curve of Wilson. On top of this wax up, we make silicone indexes that must be precise, hard, and transparent. So we can fill them with heated composite on the right measure and put it precisely in the mouth under rubber dam. So we can heat cure everything. And in the same day, we have to complete all the posterior section, upper and lower arch. And then we have to spend time in accurately define the occlusion. So we have finalized the posterior increase of vertical dimension that gives us enough room to lengthen the front teeth. We know that within 5 millimeters, patients absolutely adapt, and any symptoms resolve within 2 weeks. But this, of course, this happens with asymptomatic patients. And at this point, we can go for the aesthetic finalization with veneers on the upper and lower side. As you can see, preparation is really minimal. We basically remove corners and round everything. It's a, let's say, a cloudy preparation, very, very limited, and ready for ceramic. That is a feldspathic layered ceramic. And this is the result of the upper veneers. Very appreciated by the patient. Why? You can see the difference in color and also how much additive these veneers were. Why did we prefer veneer? Every time we can choose, we choose for the most conservative solution. And with veneer, the tooth structure removal goes from 3 to 30%. With a full crown preparation, it goes from 60 to 70. Big, big difference. And it doesn't matter whether the full crown is a metal-free or a ceramo metal one. So that's why. And the same, of course, same choice was done for the lowers, even if in this area of the mouth, an orthodontic treatment would have helped a lot. But that wasn't with energic stripping that permitted us to maintain the margin of the veneers ahead of the contact areas of the teeth. Of course, the patient is aware that in this way, the distribution, the size, the gingival contour will not be even and regular, but she was prepared for that. And we had to spend, of course, some time to accurately define a good anterior guidance that is essential for good result, final good result. And then we had to complete with 4 veneers on the premolars. It's a window preparation, very easy, cemented one by one, as usual. In this way, we could improve the aesthetic also from what we call the conversation angle. 45 degrees is the way when we talk each other, we always look at 45 degrees. So premolars are very important from an aesthetic view. On the lower arch, not only the buccal side, but also the occlusal side that has to change the color. So we made table veneers in this case. 4 table veneers on the buccal and occlusal side without that the contact area are involved. And this was the full mouth rehabilitation that we can define minimally invasive because the tooth structure removed was really limited. Here is the before and after, not too showy and with a good soft tissue response. For the natural looking smile that the patient asked for. We try to mimic nature as much as we can. And now, here is Flora, young lady, who has a problem of teeth size and distribution, and she has a missing lateral incisor. That was a genetic cause. This is not only a dental problem, because she has also a very great problem with their profile. In fact, it is a class 3, very important, with a bilateral crossbite. If you look at this case, it looks upside down. Very significant discrepancy. And also in the front teeth area, we have an occlusal plane that is tilted, an important recession with attachment loss on the canine that is in lateral position, and a differentiate crown wear between the two centrals. The general height of contour is completely uneven. What can we do for this girl? But what you have to know before planning something for this girl, it's hard to believe, but she is in this situation after 5 years of orthodontic treatment. Can you imagine that? So she was really devastated. And when she came to my office, I visited her with Davide Mirabella, the orthodontist, and we had to tell her immediately that she needed almost 2 more years of orthodontic treatment with multi-bracket appliance. And she started to cry, as you can understand. But then the worst came. We had to tell her that this was an orthognathic surgery case. And she was a fountain. She couldn't stop crying. But then when she calmed down, we discussed the alternatives that basically we had basically to choose between the extraction of the left premolar and the extraction of the left lateral to move the midline on the left and end with a cuspid substitution. I would say the opening solution to put an implant in the lateral position was not considered for economic reason, and also for the young age of the patient. And in any case, that's a surgical case. So at the end, we prefer to go with the extraction of the lateral. That is a relatively quicker pre-surgical treatment. And let us go for these realistic goals: improve occlusal scheme, improve facial aesthetics and dental aesthetics. So Davide carried on his orthodontic treatment. I want just to highlight 2 points. The palatal root torque given to the wire on the cuspids to hide the cuspid eminence. And the very accurate space distribution between the teeth that was achieved through the use of a closed coil spring between lateral and centrals. So at the end of orthodontic treatment, we have a good distribution of the teeth in the arch. The canine substitution worked well. We needed to root canal treat the cuspid that was extruded and, of course, reduced from an occlusal point of view. And then at the end of orthodontic treatment, this was the scenario. For me, this is the perfect scenario pre-restorative treatment. because the recession is over. Cuspid eminence are completely hidden. The two gingival parabols of the centrals are perfectly aligned, and we have the perfect height of contour, high, low, high, the so-called seagull wings that we are looking for. So we can debone the patient. I can tell Flora, wait, perfect. That's exactly what I want. Well, after 2 years of orthodontic treatment and an orthodontic surgery, she needs a lot of trust in us to think that this is perfect. But it's perfect before the restoration, of course. We go for the aesthetic try-in with an indirect mock-up. And we had to choose between the 4 veneer options and the 6 veneers option that helped us better with color, texture, and shape. And even if, of course, from a budget point of view, it was heavier, Flora accepted to go for the 6 veneers and also for 2 more in the lower. So now we are ready to prepare the teeth in a differentiated way, I'd say, because there is really imbalance in tooth size. This discrepancy is very difficult to treat when you have to prepare and give an uniform clearance for the lab. That's why we adopted the APT technique with a spot bonded mock-up that is prepared with a burr, so is used as a gauge. And we prepare together the resin and the tooth, usually 1.6 on the incisal margin, and half burr, 0.6, 0.7 on the buccal side. This is called is known as the Gural technique. And then we check with the silicone indexes, because it's very important to have a uniform clearance so that the lab can perform at the best. We finished everything with retraction cord. The margin, of course, is juxtagingival in this case, and a silicone impression was taken very precise. The Manuela Rascio, that is the technician that works with me, could layer his feldspathic ceramic on refractory dies, and I ended up with a nice result. And we cemented all the veneers one by one, always starting from the center and moving to the lateral. All my aesthetic targets are being centered, in my opinion, at least, because long axis of the teeth are corrected distally oriented, pointing the zenith that is never at the center of the gingival parabol, but is always a little bit distal. We have the seagull wings on the gingival contour. Papilla goes coronally from towards the center, and the same happens to the interdental angles that open the embrasures in a different way. An obtuse angle between canine and lateral, a distally open angle between lateral and central, and a very close angle, almost non-existent sometimes, between the centrals. And this smile line has to match with the lower lip line. And also the lip frame was nice with the midlines perfectly centered. So what we promised at the beginning, and in this case, the psychological impact was really important, was transformed into reality. Through good orthodontic treatment, it was tested with a mock-up, and it was accomplished with the final ceramics. Because only if you aim for the best, only if you aim for the highest result, you can get good results, as Cicerone used to say. And now, let me introduce to you the last case, Rossana, that at the time was a relatively young lady, 35 years, but with a dramatic situation from a dental point of view, of course, in her mouth. This was the clinical scenario that we had to face. Attachment loss, mobility, migration, recession, black triangles. But the weird fact in this case is that she wasn't completely unaware of her problems, except for a little mobility of the tooth number 11, until a couple of weeks before I met her. She went to a dentist in Genova, on the opposite side of Italy, with a friend of her. And okay, she went there to make a cleaning. And this dentist told her how critical the situation was. Actually, he told her that she was at great risk of losing teeth. And she was really scared. But he couldn't treat her because it was too far from her house. And he suggested her to come to my office, because in Syracuse there was a guy called Ugo Macca that could treat these kind of cases. So she came to my office with the best attitude. So she really trusted me and thought that I was the right one to save her teeth. And so we could start with the classical treatment for a stage 4 periodontitis. Scaling, root planing, open flap debridement, and then maintenance. The patient, she showed a perfect compliance, so we could move to the restorative treatment. But what kind of restorative treatment can we offer to this lady? Okay. What is the patient demand? We always start from the patient needs. And she wanted to save her teeth, but also to improve the appearance of her smile. Not easy. But basically, it was what we had as our goals. We wanted to improve aesthetics, maintain teeth, and also improve occlusal scheme. But the starting point is really critical because of okay, aesthetic expectations were high, of course, but the residual periodontal attachment is almost 50%, it's half of what we need. The morphology of the defects are mostly horizontal, so they couldn't be filled in. Bone peaks were missed, and that means black triangles. And also prognosis of a few teeth, especially number 11, were questionable. So saving teeth is not that easy either. But why these two, the upper central right in particular, was so compromised. I'd like to mention Mario Molina, Italian dentist, who explained it very well in his book. Because when we miss a tooth in the posterior area, the other teeth start to move, to bend, to rearrange. And the mandible shift a little bit in front and the opposite side to look for the maximum intercuspation. And there is a point, maybe for some collapse of the periodontal apparatus, some pocket, loss of attachment, or anything similar, that the teeth yield and they move forward and drift. So this kind of case needs a comprehensive treatment plan. So let's make this treatment plan all together. We have all the data collected here on the screen, and let's start. For sure, we can all agree on the extraction of the upper first molars because they are perforated. The pulp chamber was perforated in the past. Then we can probably agree on the extraction of the 4 wisdom teeth. And in the uprighting and on the uprighting of second lower left molar to create space for an implant. Then there are few areas compromised from a periodontal point of view where we can make different kind of periosurgeries or perio approach, but they are for sure maintainable. The tricky area is related to the front teeth. Let's highlight them. You can see how much bone has been lost on tooth number 11 and also on central and lateral right lower incisor. And on a soft tissue level, we have already recession and gingival embrasure opening. So we should complete this case after pocket elimination with a good aesthetics. Not only good, better than we start with. I know only one way to improve the soft tissue in this case. That is orthodontic forced eruption. And this is, for me, the take-home message that you should bring with you today. If you want to have a pocket elimination without long teeth and lack of papilla, resective surgery is not enough alone. Because, of course, you eliminate pocket, you have healthy teeth, but long teeth and black spaces. So you need to combine it with the orthodontic extrusion. So the whole apparatus, not only the bone, but also the soft tissue, will move coronally. And you shorten the crown and also the cingulum with the burr during the movement, because you need to anticipate any occlusal trauma that would interfere with the bone growth. And then at the end, we go with a fine-tuning of the bone crest to make it even and regular, so that the soft tissue will follow the same shape. And after a few months of tissue maturation, we make a restoration of any kind we like. So we have, with this kind of treatment, we may have a better aesthetic, but also a favorable crown to root ratio. Because at the end, the root sides will be the same, the root length will be the same, because that is due to the amount of initial bone loss. But the final crown will be much different. With orthodontic extrusion, it will be shorter. And that means a better leverage, less load, and a better prognosis. Let's sum up this point that is very important in my opinion. If we have a deep pocket and we have already treated it, so there is no active lesion, there is no bleeding, and we start to move the teeth coronally with a light orthodontic force, the pocket depth will be reduced. The intrasulcular microflora will change and become aerobial, and the crown to root ratio will be drastically improved. So this is the orthodontic treatment that we accomplish, as is Davide Mirabella, through a strategic bracketing to align and flatten the curves and the arch. And then we also move coronally through the forced eruption, the teeth that have deep pockets, always with light forces, so the bone can follow. The goal is root alignment and bone peak movements. Sometimes we need also to rebracket to move and get more bone arise. So this is the end of the orthodontic treatment. The usual question is, when do you stop orthodontics? And the answer is when the deepest defect has reached the contralateral level. As you can see in this picture, the mesial part of the defect in number 11 is on the same level of the number 21. But when this kind of tooth move, on the other side of the tooth, the bone move also obliquely, and it may create an infrabony pocket with the adjacent tooth. Only if we move also this other tooth, we could avoid this kind of event. But in that case, we will end up with an uneven bone contour on a coronal level. So what we do in this case is going with a periosurgery, a bone surgery that level the bone crest, recreating the harmony and an very even contour between canine, lateral, and central. And then this is the before and after the surgery. No pocket, of course. Very regular transition between high, low, high, and the two central on the same level. So after few months of tissue maturation, at least 6 up to 1 year, we are ready to prepare them. You can appreciate from the periapical the bone peak level. Of course, the tooth that is extruded must treated from endodontically. Also, the occlusal stability has been improved. We have the correct space distribution for implants and bone ridge perfectly ready for implant insertion, that in this case is really a piece of cake, I would say. Little bit more complicated is the preparation of these teeth, because they have a different section. course, the number 11 is a tapered tooth. We are almost at half of the root. So it's thinner than number 21. And also we are preparing one crown and one veneer. That's why I make a very light chamfer, or you might also prepare with a feather edge, to introduce a crown over contour that can give some support to the soft tissue and close black triangles. Lithium disilicate is the perfect material in this case because it performs well both in bonded and non-bonded kind of cementation. So we have this final result completed with 4 lower veneers. Well, and this happens thanks to extrusion and reshaping. Thanks to extrusion and reshaping, we can control bone and gum architecture, improve clinical crown height, and improve crown to root ratio. So all our goals have been fulfilled. First of all, pocket elimination. Absolutely no probing at the end of the treatment. The crown to root ratio, as we proposed at the beginning, has been improved. And you can see it from this cartoon. Also the occlusion and the teeth distribution and the bone peak distribution is very, very good. And the aesthetic has been improved. But what is really important is stability in time. After 15 years, soft tissue and hard tissue haven't changed at all. And also the teeth have a stable alignment and the occlusion is stable. And the patient, of course, uses a retainer along the years. So in conclusion, if you want to treat these kind of cases, you need to see problems and find solution. But you can see only what you know. So the base is knowledge. Knowledge of biology, knowledge of aesthetics, and of function as well. And the treatment plan, I suggest to you, has to be tailor-made on patient needs and desires. And you must use as many arrows as you can. That's why interdisciplinary approach is so important. Is for me the real key factor. And with this, I want to thank you for being with me. I need to thank my staff also. And if you want to communicate with me, you can find here the website and my email. Thank you again.
Thank you, Ugo. Well, we already started receiving some questions. Can I start making you some questions, Ugo? Are you ready?
I'm ready, yes, of course.
The first one is, how do you avoid the teeth to be all connected to each other interproximally when doing the stamp?
The stamp? You mean the mock-up?
I think.
Oh, okay.
I think it means mock-up.
Yes. Okay. I understand the question. That's the most difficult part of the treatment, of course. And it depends on the way you make the wax up. You need to stop the wax a little bit before the contact area, leave some tooth visible so that the index the silicon index goes there. And then, of course, you don't etch that area of the tooth. So even if some materials infiltrate there, then you can easily remove with the strips.
Okay.
I hope this is...
But can I ask you something else? When
Yes.
you put the mock-up, you put the spot etching, spot adhesive, or you do it full crown?
When I make... No.
When you put the mock-up, and you said that you etch.
But the mock-up I use is the one that I use with the front teeth. It's just a try. Okay.
Right.
So then I remove immediately after patient acceptance. It's just to discuss with the patient, the mock-up. It's different when I use it for preparing the teeth, let's say the Gurel's technique, if we want to use this definition. In that case, if I make some spot etching, yes.
Another question. It's about where there's written, when you do orthodontic extraction of the tooth, do you always perform also a root canal treatment, even if the tooth has to be extracted?
Yes, you don't want the patient be in pain for all that time. Yes, absolutely. In that case, usually you move down the teeth up to the apex almost. So you need to reduct a lot the tooth. So you immediately start with root canal treatment. Yes.
The other question is always about the orthodontic extraction. And this tells you, during the orthodontic extraction, do you reduce the tooth coronally? If yes, when?
Okay. It's funny that I didn't show orthodontic extraction, but the questions are about it. Yes. I can connect to the previous answer. Just at the beginning of the treatment, we make a root canal treatment and reduce it of a couple of millimeters. And then every time that there is an activation of the orthodontic appliance, I grind the tooth at least 1 millimeter, sometimes even 2 millimeters in advance, because I want to avoid absolutely any contact, not only in occlusion when the patient closes them out, but also during the movements. So you have to consider and check everything. And you have to consider that the tooth that has to be extracted orthodontically usually moves coronally very quickly because it has very low amount of attachment. So you have to consider to see the patient again within 1 week, every time.
Okay, so we say every week. Just to check.
Every week, at least 1 week within the first week after orthodontic activation. Okay.
And there's another question. Do you think that in multidisciplinary approach, the orthodontic side could be substituted with aligners?
Wow. In some case, yes, of course. But when you want to be really precise, and especially for the extrusion, you need to move the teeth along its long axis. That's what Davide teaches, and that's what I learned from him. Okay, it's very important that tooth moves along the long axis without any bending of the root, especially buccal when bending, because in that case you would have resorption of the root of the tooth. So yes, again, it's possible sometimes, but you need to control forces. And I need to, let's say, to say one important thing. I'm not an orthodontist, and I don't do orthodontics, okay? So I can answer, but it's not my job.
There is, I think, the last question, and it's asking, one moment, in the multidisciplinary approach, the implant, in which position it is? I think, now, reading this question, I think he means that if you do first implants or first orthodontics, or in which the timing, I think they mean.
Emmanuel, I'd like to answer, but it's not clear for me the question.
Maybe I think that he is asking because the implants you cannot move them with orthodontics. So he's asking the timing of when you place the implants, or else if you use the implants.
Let me try to answer. In a conventional treatment, we put implants at the end of orthodontics. Sometimes we need to put the implant before orthodontics if you use it as an anchorage. So you need to plan it with a setup before.
Okay. Ugo, this was the last question. So thank you very much for your time, and thanks for sharing with us all this knowledge that I think it's very, very important. I want to remind everybody that the next webinar will be in September with Sydney Kina, and it will be a special event in Spanish language. It will not be at 2 o'clock as usual, but to help also our friends from Latin America, it will be done at 15 Central European time. Correct, Valentina?
Yes, exactly. And we would like to advise as well our participants that at the end of the webinar, you're going to receive an email from us with a link to satisfaction survey. So please, if you can take a couple of minutes to answer it, it would be really helpful for us because your feedback is really, really useful. And then we would like to remind all of you also of the fact that you have the chance to register in any moment, even to the last appointment of our webinar program, by having a look at our Educational Hub social or website. And if you would like to watch the recordings of the previous webinars, don't hesitate to visit our Zidu Hub, and I'm glad to share with you the link in the chat box. Exactly there, in the following weeks, you will also find the recording of today's webinar. So we wish you a great rest of the day, and don't forget to stay tuned.
Thank you very much, everybody. Thanks, Ugo. Thanks, Valentina, and goodbye to everybody.
Goodbye. Thank you again.
Thank you. Goodbye.
Bye-bye.